Hello and welcome to ADEC in Conversation, special series addressing COVID-19. I'm your series moderator, Dr. Jill Harrington, coming to you from our nation's capital, the Washington, D.C. area. Joining me also here in conversation is Mr. Isaiah Allen, Executive Director of ADEC, coming to us from Minneapolis, Minnesota. Today, we welcome our panel, some who are clinicians, peer support leaders, advocates, and scholars, or all of the above, in the field of suicide postvention and prevention. And today we'll be talking about the impacts of COVID-19 on grief, loss, mental health, and suicidality. So joining me here today is Dr. Jack Jordan, clinical psychologist, retired private practitioner, as well as co-editor of the book Grief After Suicide, and author of many numerous publications in suicide, loss, and postvention. He's also a trainer, and Jack is joining us here today from Pawtucket, Rhode Island. Also joining me here in conversation today is Kim Ruocco. Kim's a social worker as well as a suicide loss survivor. Kim has been the forerunner in leading best practices in suicide postvention for the military and veteran families at the Tragedy Assistance Program for Survivors, otherwise known as TAPS. And Kim is currently the Vice President of Suicide Prevention and Postvention at TAPS. We welcome her here today from Newburyport, Massachusetts. Finally, we have Dr. Melinda Moore, Assistant Professor of Psychology at Eastern Kentucky University and licensed psychologist. Dr. Moore has spent a great amount of her career focused on post-traumatic growth after suicide, as working very closely with Dr. David Jobs on an evidence-based psychological treatment for suicide called the Collaborative Assessment and Management of Suicidality, otherwise known as CAMS. So I'd like to thank you all today for joining us and taking time out of your busy lives to talk about the impact of COVID-19 on mental health and potential for suicidality, or working with those who are suicidal, and some of the other factors. So before we get started here today, Jack, I'd like to kind of get started with you. We all work, the four of us work in the field of suicide postvention pretty closely. And this conversation came about because we do have some great concern for how caregivers and clinicians and family members are helping individuals and treating individuals that may be suicidal, and also how this pandemic may be increasing or influencing risk. And that idea for this discussion and our panelists emerged. As we saw with Governor Cuomo about a week ago, he talked about the effect of mental health on people going through COVID, as well as those who had prior mental health conditions before COVID. And that's what I want to talk about a little bit. You know, before this pandemic, people were struggling with mental health issues, and there's a range from challenges of stressors to severe mental illness. And also COVID, this pandemic, may also be impacting people in their mental health with possibly short-term or long-term consequences because of this crisis. And also, there are those grieving prior to COVID, because of non-COVID related deaths that are happening now. I have many clients who are coming to me. I had one yesterday. You know, she's really feeling what she calls the additional burden of grief, of grieving her daughter who died 3 months ago from a health-related condition, because she's unable to get hugs from her family members. She's unable to reach out to people, to be in that physical kind of support she needs with others. And so it's this additional burden that's really making for a much more distressing grief process for a lot of people. And then also those who are going to be bereaved by COVID. So I thought we'd start out with you talking a little bit about introducing us to this whole concept of how mental health is affected with COVID, and particularly what aspects of grief are embedded in this experience of people living through the pandemic.
Right, good, thank you, Jill. Welcome to everybody who's joining or listening to this. We're glad you got to us and that you decided to join us. We're going to do our best to make this a helpful learning experience for you. As Jill said, I'm going to start off talking a bit about grief, sort of grief 101. What do we mean by that? And also what are some of the losses that are embedded or stressors that are embedded in living through something like the COVID pandemic. What is grief? I'm going to give you a one-sentence definition of grief, and I'll say it and then repeat it for you, and then I'm going to break it down into a couple of components. Grief is a whole person response to the actual or threatened loss or separation from anything to which we are emotionally or psychologically attached. Let me say it again. Grief is the whole person response to the actual or threatened loss or separation from anything to which we are psychologically attached. Now, what does that mean? Obviously, people, when they think about grief, grief is about what people go through if they lose someone to death. And that's part of what we will be talking about today, but it's not the only thing. It's not the only kind of loss that is embedded in living through something like the COVID pandemic. So we can lose important people, obviously, through death. We can lose them through divorce. We can lose them through migration if they leave. Other ways in which someone who's important to us and who we feel connected to also is no longer available to us, and we're separated from them involuntarily. But we also can have grief reactions to other things that are important to us. For example, if you had a fire in your house and you lost a whole drawer full of precious photographs, people would grieve about that because those photographs have a lot of meaning for an individual, and the reactions would be a kind of grief reaction. We can lose important rituals in our life that have a lot of meaning, bring us pleasure and purpose and satisfaction. For example, every morning you may have coffee with a close friend, and COVID may interrupt that and make that not possible to do that. Every night you and your wife go out to dinner on Friday evening. It's a ritual for the two of you, and the loss of that. And then there's obvious things like birthdays, holidays, etc. So something like the pandemic can interrupt or even end the ability to have those kinds of important, meaningful rituals, and people will have a kind of grief reaction to it. People lose important roles that they play in their life and their identity that is attached to that role. If I were to ask you, tell me who are you? And I kept asking you over and over again, you'd say, well, I'm this person's parent, this person's partner or spouse, I'm this person's employee. Much of who we see ourselves as being in the world is connected to the roles that we play in connection to other people. If we lose that availability of that other person, then we may feel like we've lost some of our own identity. I don't know who I am in the world now that I've lost my child to death, or my child is sick and I'm worried about them. If I've lost my job, the pandemic is playing havoc with people's financial security. And we're attached to being able to go to work and to count on the money that we earn from it, et cetera. You lose that, you can have a kind of grief reaction. So grief is really about loss and separation. One last form of loss that's really important to understand and very relevant to the pandemic is what psychologists or mental health people call a person's assumptive world. And our assumptive world is all the things that we take for granted about ourselves, our world, who we're connected to, and why we're here, what our purpose is, that all can be upset or dysregulated by a loss. These beliefs, for example, help you navigate in the world. A wife may believe my husband will always be there to help me and help me to handle things. But what if your husband gets COVID and is either ill and in the hospital or dies, and they're no longer available to you to serve that role for you? We like to believe that we can protect ourselves and our loved ones from bad things that might happen. And we're all hopefully working to try to protect ourselves and those that we love from the ravages of this infection, but we can't always do that. And that's a loss of a sense of safety or security in the world and predictability in the world. And familiarity in the world. Embedded in losses are the loss of the future that we expect to have. So a husband and wife might expect to, retire and travel and visit their grandchildren and always go to, Europe. They've never been there, and all of that may be lost if one of the people die or they become significantly disabled. So all of these things are really losses that are embedded in something like COVID that don't get recognized as losses per se. We think you're grieving if you lost someone to death. No, you're grieving if you've lost anything that's emotionally important to you and that you're attached to.
Kind of like, as we say, sometimes the invisible losses that people
Exactly.
You're living through them, and they're not always recognized. So there's kind of a disenfranchised grief that people may be feeling. Because it's easy to kind of recognize a loss that's physical and tangible. Some of the intangible losses aren't. I want to talk a little bit about, grief is a normal and natural reaction to loss.
Yes.
It's not a mental health. It can affect mental health, but it's not a mental health disorder. So how do you think grief right now to all these other non-death related losses and death related losses might be impacting people's mental health?
Well, I think people think of these things when they think about them. They don't think about them as grief per se, but they think about them as stressful. And I think most people recognize that they're enduring or having to deal with stressor events or stressful aspects of how the COVID virus is changing their life. Really, grief is a response to when things change in our life, usually when they change in a negative way, and we don't want that change to be happening. But that change can be anything from our daily routines and habits to our people that in our mind are there if we need them, even if we're not using them. And so most people understand that that kind of change is very stressful. What we're adding on today is that those are also likely to produce a grief response. And all of that change, too much stress, overwhelming stress, we know is a major contributor to people's well-being, mental well-being, or their lack of mental well-being. I think too many things change too rapidly.
As I mentioned earlier, COVID isn't happening in a vacuum. People had lives prior to COVID, and we're kind of moving through this right now. There were those who were suffering losses prior to COVID. Those who were suicide loss survivors, newly bereaved, people who were grieving the loss of family members to accident or illness. How do you think this is affecting them right now?
Well, I guess the way I would say it is that I think going through additional stressor events in one's life, such as all the kind of havoc that COVID can create for people in their lives, kind of turbocharges whatever one's grief response is. If you were grieving a loss prior to this happening, even if it had nothing to do with COVID, it can feel like your ability to cope is overwhelmed. It can certainly dysregulate your biological functioning. You may have more trouble sleeping. You may have more trouble. You may lose your appetite. Your bowel functioning may be upset. Your whole body responds to this. Grieving is a body, mind, and emotion response. That's why I call it a whole person response. Your thinking can change, and if you lose someone, you may be feeling kind of both sad, but grief is a lot of other emotions besides just sadness. It can be intense yearning or wish to have the person back. It can create anger and kind of fury that you have been sort of robbed of the person that you think should be there and you expected to be there. It can create tremendous anxiety, tremendous fear and anxiety about how can I cope? How can I, if we can't understand what's happening to us and why it's happening and what we can do to manage it, that raises our anxiety level automatically and we can feel helpless. Also, COVID is creating isolation. Literally we're being told to stay away from other people. I think it's important to make a distinction between, it's being called social isolation, although I read that the World Health Organization recently changed that language, because we're really being told to keep physical distance from other people. We are not being told to isolate ourselves socially or psychologically from other people, except in a physical way. But because of things like the telephone, because of Zoom calls, etc., we can feel connected to people quite effectively, actually, even though we can't be physically close to them. Loss can also produce feelings of guilt and responsibility and exaggerated responsibility. It's very common for people when they lose someone, especially to suicide, but not just to suicide, to feel like, well, I could have and I should have done more. I should have been better at this. Because we've got this terrible infectious disease, and most people who get infected don't know how they got infected or where that happened, then people can fill in the blank with all kinds of things. Well, I shouldn't have gone to the grocery store, or I should have stayed away from my husband. I knew he had diabetes and now it's my fault. I gave him this, and people can feel guilty about that in a kind of irrational way, but nonetheless, we have those thoughts at least. And lastly, all of this can just be very dysregulating. If you have somebody who you're used to being in your life, you've been married to somebody for 25, 30, 40 years, and all of a sudden they're gone, or in a short period of time, it's very disorienting, dysregulating, and it takes a period of time and effort to sort of adjust to this changed world that you have to live in.
It seems like COVID really has a lot of similarities to sudden loss.
Yes, this is coming on people pretty suddenly. It is a very sudden thing that's happening. People are dazed and kind of confused and disoriented by this, and understandably so.
So for care providers, like mental health workers, what effect do you think this is going to have? I mean, a lot of the interviews that I've read and also seen, and seeing nurses crying, having to be bedside by patients, us in the mental health field, we're taking on a lot of people's grief and anxiety and overwhelming sense of fear. What do you think the impact to the care providers, the healthcare workers, the mental health care workers might be?
Wow, that's a big question. First of all, it's crucial to remember that we are, at our foundation, no different than anybody else. We are human beings, and we have the same reactions that other human beings do. And although we may feel like sometimes because we think we know a lot, or we've dealt with loss or grief before, or if you're a medical provider, you've dealt with lots of medical problems before, you've had people die before, you may feel like, well, I'm used to all this. But we all have thresholds beyond which we can start to feel overwhelmed by what's happening. The core of it, to me, I would describe, Jill, as helplessness. As mental health providers, as medical providers, we like to believe that we can help and that we can fix things for people, that we can make it better for people, that we can relieve their physical and emotional suffering. And when we can't, and when we're flooded with people for whom we cannot, our tools and our bag of tricks, if you will, aren't working because they're either too many or because literally the situation cannot be fixed, that can leave us feeling helpless. And that's both the core of the trauma response to me, is when something bad is happening and you can't fix it or do anything about it. And also an exaggerated, some of these things we're talking about, anger, exaggerated sense of fear, anxiety, exaggerated sense of guilt or responsibility. So caregivers can feel all those things also. And I think hopefully we'll have a little time today to talk about what people can do to try to help themselves, whether it's the people for whom we're caring and ourselves also.
Yeah, because being, in social work, we preach a lot about self-care and boundaries, but we're in mental health, I'm not talking just about social work, we're sort of the worst offenders. I know my caseload has definitely, of my clients, has doubled in the last 2 weeks.
Yep.
And, you know, there's also that feeling of feeling helpless, but trying to be helpful.
Yep.
We
Yep.
can't
Yep.
always usually take up that charge where there's a great need.
We have to practice what we preach, to put it in a sentence. Easier said than done.
It is, especially when people kind of are in need your care. And there are a lot of people who are suffering very stressful responses to this. And those who also who were dealing with mental health issues, and that range again from, and I like to really always take time to educate that mental health, it's a spectrum of health challenges to severe illness, just like any like physical illness. You can have an illness that's kind of like a cold to an infectious disease. So with that said, it's very hard with the need being here. We're kind of on the front lines, also rising up to the challenge and the charge. So I think it's important also to talk about how this can influence the practitioners and caregivers,
Right.
not the clients and individuals. But with that said, Jeff, how do you think, Jack, how do you think that this kind of can affect risk to someone becoming suicidal?
Risk for suicidality? Sure. Well, let me say a couple of words about suicidality. And again, this is Suicide 101, and it's going to be very abbreviated. Suicide's an extremely complex phenomenon, and to try to reduce it to just a few observations or sentences is inherently going to be limited. I think it's important to remember that I like to call suicide the perfect storm. It is not the result of just one thing, even a bad thing that happens in a person's life. People don't kill themselves just because they've lost their job or lost their financial security or even lost an important person in their life. It's the coming together of multiple factors in just the wrong way that create the conditions that allow suicide to happen. It's easy to focus on something like job loss or getting sick with COVID or something like that as the cause. But in all of those things, we know that there are lots of people who don't become suicidal, even though they're going through the same kind of stressful thing. So it's multiple things that have to do with our everything from our neurobiology to our social environment to our attitudes and beliefs about suicide and ourselves and our ability to cope. We do know that losses can be a significant contributor to suicide, someone becoming suicidal. And I already mentioned some of these things: the loss of one's sense of identity. Actually, I think this is important, particularly relevant to COVID as it produces deaths, not just people being ill or sick, but deaths. Sometimes suicide can be motivated by a wish for reunion with someone. I don't want to live anymore. I want to die and be with them. And that can be a motivating factor. And we're going to see a lot of excess mortality in the country as a result of COVID. And we may see an increase in suicidality as a result of that. So there's a lot of things that can contribute to suicidality, but we know that stressor events can be one of them. And we don't have time to go through the other things that are sort of necessarily risk factors for predicting it. And suicidality, by the way, can also be on a continuum from what's sometimes called passive suicidality. I don't care whether I live or not anymore. You know, my reason for living, my purpose, my wish to be alive, my pleasure and my joy in my life is gone. My child has died, my husband has died, etc. That can be a more passive kind of thing, thoughts that people are having and feelings without action or behavior, all the way up to people actively wanting to die and thinking about how they can make themselves be dead and having a plan and even putting that plan into effect. It's important for clinicians and caregivers, first of all, always, 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 I have this in capital letters on my notes here, is to ask, when in doubt, if you think someone might be thinking about hurting themselves or wants to be died. You get that sense if they're telegraphing it, even if it's obliquely, ask directly about it. Even, it's amazing, even mental health professionals get uncomfortable or skittish asking people about whether they're thinking about suicide or feeling suicidal. Please ask. It's much better to ask and be wrong than to not ask and find out later that the person was suicidal. There's other things to do that I don't know, we'll see if we have time to talk about. If you then get an answer that says, yes, I am thinking about suicide. Yes, that is on my mind. Yes. And that gives you more reason to be concerned or worried about them, about what to do about that. But I want to share the time here, so.
No, and it's so important. I mean, just to ask, and Dr. Moore is going to talk to us a little bit about intervention. I recently myself, to share, I had a 35-year-old client who recently lost his husband. They were very close, and we were doing a teletherapy session, and he was, the things I was listening in for, and I just asked him, I said, Dave, do you have any thoughts or intents or plans to kill yourself? And he said to me, no, but I want to thank you for asking.
Yep.
So
The way that I encourage caregivers to ask is, you're really having a hard time. I can see that now. Does this ever get so bad that you don't care whether you live or not? Which is really asking about passive suicidality. And if someone says yes, then you start to explore it with them. Ask them to tell you more about what are their thoughts, how often are the thoughts, how strong are the thoughts, are the thoughts being translated into behavioral action? Like, not only do I think about or wish I was dead, but I'm saving up pills so that I could make an attempt, etc. But the opening question can be, is this ever gotten so bad, and you ever felt so much despair that you find you don't care whether you live or you wish you were dead?
yeah, and it's often a conversation we have in session, and so that comfort level of knowing that your clinician is not afraid to ask those questions.
Yeah, I want family members not to be afraid to ask the questions also. Family members and friends. This isn't just for clinicians. This is for anybody who's worried about someone else being suicidal.
Right. And it's important. I mean, he had one previous suicide attempt before, back in 2017. So very important that I think people feel comfortable in being able to trust somebody that they could talk to about it, because ignoring it could be very dangerous.
Yes, right. And also just to take the air out of an old shibboleth, which is that, oh, you don't want to ask someone about suicidality because you might put the idea in your head. People don't become suicidal because somebody asks them if they're feeling suicidal. That's just not true, even though it's widely feared or believed. And conversely, if someone is feeling suicidal and you ask, you often get most clinicians have had the experience that you just mentioned, Joel, the person saying, thank you for asking me. It means that you care and that you're noticing what's going on with them. You're tuning into them. And that's a valuable thing. That's a good thing.
We had agreed that, because he's a person who likes direct questions. So we agreed initially that we would always just ask up front. So it's important to kind of have that dialogue with your clients.
Yep.
What do you think, my last question is, because we're going to get to talking about things that are helpful. But as I was listening to you, and also working a lot with my own clients, what do you think the role of hopelessness means in all of this? Because there are many people, there are those, again, there's going to be such a variation, because people are, we're like a kaleidoscope. There's so much variation between all of us. We're all individuals as snowflakes. There are those who are maintaining the kind of their approach to this and how they think about things is, this is going to pass, it's temporary.
Yep.
And there are those who feel very hopeless that the world's never going to return to pre-base normal. Very hopeless that this is going to drag out for a very long period of time, very hopeless about ever regaining employment. Can you talk a little bit about the role of hopelessness in all this? Sure.
First of all, there's considerable research that suggests that hopelessness is associated with an increase in suicidality. In a sense, I've come to think about suicide as a kind of surrender. most people, not everybody, but most people who die by suicide have often struggled for a long time to fight those feelings, to keep going, to hang on. And there's a kind of surrender in which people feel emotionally, psychologically exhausted and hopeless, like nothing's going to make it better. And I don't have a magic way to deal with that, but I encourage people, both caregivers, to pass this on, but also people who may be feeling that way that are listening to this. I once saw this amazing bumper sticker that sort of didn't change my life, but had a profound impact on me. It's so simple. And it's really the basis in some ways of certain kinds of therapy, like cognitive behavioral therapy. There's a bumper sticker that just said, don't believe everything you think. And that's so true, is that what you are feeling in this moment is not necessarily the whole story or the reality or the truth. And one of the things that, for example, Buddhism as a religion teaches is that everything changes all the time, including your own thoughts and feelings, and don't get too attached to any one thought or feeling as the truth about things, because it will pass also. And that's actually a comforting thought. It's hard to deal with change, knowing that everything will pass, but it also can be comforting knowing that when we are suffering, that suffering is not eternal. It's what you're feeling right here and now, but not forever or eternal.
I actually have that bumper sticker, but it's actually a little photo in my office. Don't believe everything you think.
Perfect, yeah.
We do a lot of thought evaluation and kind of evaluating the evidence for human growth through pandemics before with some of my clients, to really try to help them, evaluate and reframe those thoughts for themselves. Also,
be aware that their thoughts you're having now, that's not the same as the truth.
And that feelings sometimes aren't always facts.
Exactly.
I could feel like Wonder Woman right now, but I may not be her right now in this moment. little superhero humor. Well, Jack, I want to thank you. Is there anything else you'd like to share with us before we kind of move to our next speaker?
Just to encourage people to hang on and to trust. This will pass. We can get through this. Yes, there are going to be losses, including losses through death, but I think that we are going to get through this, and human beings are an amazingly resilient species, and you have to sort of hold on to that hope, and also try to convey it to people who we are caring for. Not in a Pollyannish kind of way that denies how awful it is, what people are going through. It's a real art to be able to be present for that and acknowledge it, but also to offer people hope. And that hope can focus on how can I get through the next day? Maybe tomorrow will be better, not just this is all going to be better a year from now. A year may feel too far away for many people, but can I get through this day or the next hour, and what plan can I make for myself to get through this day? Maybe enough to help someone hold on.
So maintaining a sense of realistic hope.
Yes, exactly.
Dr. Jordan, thank you so much. Now I'd like to change the conversation. Thank you for all those insights. And we're going to circle back to you when we do some questions and answers at the end of the panel.
Okay.
I know you talked a lot about sort of the individual perspective, a little bit about families, but I'd like to turn to Kim Ruocco, who's going to talk a little bit about, her work with families, supporting families during the pandemic, including special consideration for our military and veteran families. Thanks for joining us here, Kim.
Hi, everybody. It's so nice to be here with colleagues that I respect and have taught me so much. So I'm really glad to be on this panel today, and I hope it will help you respond to some of the families and individuals who are really suffering during this time. I mean, we know that our families are under a tremendous amount of stress. In fact, just this morning, I heard that the National Disaster Hotline had an increase of 891% of their calls, with people that are calling in all kinds of different distress, starting with just their basic needs. When you think about a hierarchy of needs, people are dealing with unemployment, financial issues, And then just access to your basic needs of supplies, getting, food, and I think this is maybe why people are hoarding toilet paper. Just getting your basic needs met is sometimes challenging because you can't afford it, you can't get it delivered, you're afraid of exposure. There's also the challenge in getting your basic psychological and physical healthcare needs met. How do you access them? Is the access different? Can you go to your doctor? Can you go to the hospital? So people are under these stressors and anxiety about how do we get just our basic needs met. Additionally, I think families are really having this existential crisis of facing maybe their own mortality, and also worried about the health and well-being of their loved ones, which is increasing a lot of stress for people. And people who have pre-existing either mental health issues or physical health issues are in even more different stressors, because they are now maybe exposed to a germ or a virus that could kill them. So we have dynamics among families that are changing and under a lot of pressure. There's these changes adding to these challenges, and there's extremes of changes in living situations that go from living alone and maybe being isolated and kind of on your own to fend, all the way to maybe having multiple family members in one setting that are trying to navigate living in close quarters without the ability to have the coping that they used to have, which may be get outside or go with friends or go to, just your recreational things like dinners. And I'll give you a really good examples, a couple of the people that we've been helping support, and just really how this pandemic has impacted their mental health. We have an elderly woman who lives by herself. She used to she have pretty severe depression, but learned to cope with her depression by leaving every day, going to the diner downtown. She knows everybody behind the counter. She'd have conversations. They know her name, and then she'd go to each family member and she'd help, she'd do a little laundry. She'd hold the grandchildren. She'd, do these things on a daily basis. So the fear of being exposed to the virus has kept her alone by herself. So being there and having, the things that usually keep her going taken away, and then adding to that the difficulty in getting your basic supplies and needs met with the fear of being exposed to a virus is a lot of added stressor to an individual. And at the other extreme, we have a family that the mother in that family has a pre-existing illness where she's on medication that makes her immune system decreased. In the meantime, she has a husband that works at the hospital, is an essential worker, has to go to work every day and then come home to the home with maybe carrying the virus and contamination. So the stressors for each of them, am I going to get infected by my husband? How do I keep myself safe? And for the husband, am I going to infect my spouse, has created a lot of stressors among the family. So this has led us really to families feeling very vulnerable, very helpless to control these stressors and these things that are maybe threatening their lives or their basic ability to survive. And that's leaving families really having to trust one another in a way that they never have before. So trust has become a big issue. Did they wash their hands? Did they take care of themselves? Will they bring the infection back? Am I going to infect my loved one? So this trust is really a challenge right now, and something that families are having to navigate in a very different way.
How about living just under the same, those are a lot of great points and a lot of stressors you bring up that, we didn't know families were experiencing right now, but how about just living under the same roof, spending that 24/7 time together? I have a client who, she's a high-risk pregnancy. Her husband's in the military and he works in the healthcare part of the military, and they've actually now kind of told him he needs to stay at home. So he's feeling not really angry at her, but just angry at the whole circumstances of having to stay home and you know, it's very stressful. So when people are around each other so much, we can get on each other's nerves.
Yes, and there's this balance of staying safe, of working with each other, with trusting each other, and also setting boundaries, right, around how do we do this. And so families are having some challenges in expressing what their needs are, setting the right boundaries, trusting each other to be able to stay safe, and figuring out how do we communicate these things. So we as caretakers, providers, clinicians really have to help families set boundaries, communicate clearly their needs, and help them set up a family system that is working under incredible stress, but can shift from butting heads and mistrusting each other and feeling very vulnerable and then having fear, to communicating your needs, getting yourself feeling like you can be protected, and connecting with your family around that. And very often that's helping families really be clear about what they need from each member to feel safe, to decrease anxiety, and to function in a very difficult situation.
So what about families where there's pre-existing, I know I'm going to give you a question on the fly, high family conflict, and these things, never existed before they had to be quarantined together, and people didn't get along and they were coming in to see you because there's a bunch of conflict going on?
Right. So we are seeing, according to the Department of Social Services, an increase of domestic violence. And from our first responders, we know that increased calls around domestic violence. And this is very worrisome. And so I think it's really critical to ask those questions about how are they coping, how are they resolving conflict, and how can they stay safe within a family that's under a lot of pressure. And that may be changing the coping styles that they had previously. What are other ways that family can cope with stressors and express their anxiety other than have it escalate into some kind of domestic violence or some kind of volatile situation? And family systems need a lot of help in that shift, because things that they used to maybe do, like go to the gym or go for a run or go out for a dinner and get away from that family system, are now put into a fishbowl, if you will, and with added stressors, and they're trying to navigate that. So families really need a lot of help to find out they're coping, and maybe helping them with alternative things that they may not have used or may not have thought of before, like mindfulness or yoga or breathing or writing or drawing or some other, innovative alternative ways of decreasing stress, expressing your anxiety, and coping with what's happening for them.
I know some families, they've had to basically, as part of the coping, is families had to be placed in different homes because they just be under the same roof together. I know one of my students shared with me, she has a very small house with her children. She's in her 30s, and what they did to help cope was to assign each person their area of the home.
Yes.
They have, their
Yes.
private area, and that has been really helping. But I'm kind of concerned too about people falling on, we all don't sometimes use healthy adaptive strategies, and kind of our adaptive strategies have been one where possibly the increase in substance abuse is happening, and families are compressed under all the stress and pressure, combined with unemployment and concerns about job loss and mental illness or mental health issues. What do you think some of those specific challenges, how do you think that's impacting risk to families?
Yeah. So many families are navigating this kind of thing right now, and they formally could go to an AA meeting or something, but so there's a shift in the way we have to access our support systems. So us as providers can help them connect in different ways to those support systems. Calls to mentors, that under AA, or having virtual meetings with behavioral health, helping them cope in different ways through breathing and mindfulness and yoga and other, going for walks and those kinds of things, versus grabbing the substance, is really something that I think they're having trouble navigating, and we need to guide them and connect them with the right resources that may be different than what they're used to to in the past.
How do you think this is all impacting risk? Everything
Yeah.
you could share with us here today.
Yeah. So I think there's a lot of factors here that are increasing risk for our family members. You know, one of the things, you know, that we have a lot of families out there that are newly bereaved, for example. And so their rituals that they used to have for bereavement may not be available to them, right? So they may have been able to go to a funeral before, connect with others, express their grief, and find a sort of path for that grief. Sitting Shiva, you know, that is not something that's able to be done right now. People would sit with the, you know, together, and that's part of the ritual that helps connectedness, it helps with the grief, it helps them move forward. So when you take away those rituals that decrease stress and promote connectedness, you're increasing risk. So we've got to find ways to continue that sense of connectedness, continue some rituals for their bereavement, and get families finding alternative ways to memorialize and remember their loved ones. So I think risk has gone up, but we also have to, so it's important to balance that with protective factors like keeping connected, like finding meaning in what's happening to the family now, maybe through living a different life in honor of the deceased, and incorporating that into how they're communicating at home.
Can you share with us a little bit about, because TAPS helps military families and veterans, and we know the power of peer support. We also know the power of connectedness, social connection, social support, emotional sharing is so important. Physical gathering with retreats and other things to bring the bereaved together. We've all found these things. Those of us who work in bereavement know that these things can buffer some of the stress of grief and, you know, create a sense of connectedness, of not feeling so alone. So could you share with us a little bit about how you're doing that at TAPS?
Yeah, so a couple things. First, about the military, veteran, and service member families, and kind of what's different about them in this pandemic is, you know, first of all, there's additional challenges. So many of our service members and veterans are suffering with illnesses that were from exposure of their service that now make them more at risk for COVID and for being critically ill from COVID. At TAPS, illness is the leading cause of death with suicide for incoming referrals right now. We're getting tons of veterans and service members coming to us with respiratory illnesses, leukemias, and cancers related to exposure. So that is an added stressor for these military families who, if they're exposed to COVID, it could be lethal. So there's a lot of anxiety in that population around being exposed to COVID. Also, our service members and veterans, especially veteran populations, are very often first responders. National Guard members, reservists, and veterans very often work in first responder jobs during the day. Those first responders are regularly being exposed to the virus and then having to come home to their families. So there's this fear among them that not really for themselves, but more for their families. Am I going to infect my family and come home and infect my family? The good news about our service members, their veterans, and their families is that they are an incredibly resilient group of people. And so tapping into that resilience and that coping is really important. They also are ones who are looking for meaning and purpose. So tapping into their ability to use what they've learned to help others is incredibly helpful. So at TAPS, we've shifted from an in-person retreat style and conferences to really a proactive outreach approach. So we are not only increasing our online supports with daily coffees, daily talks, daily chats, daily support groups, but we also we have tripled our outreach team, and they are calling survivors every single day. We had 52,000 calls in the last few weeks of survivors. We are just calling proactively, doing caring outreach. How are you doing? Are you okay? What are your challenges and how can we help? So I think as supporters, we have to proactively reach out to families, find out how they're doing, assess for risk, and offer them alternative ways of staying connected, finding a sense of belongingness among this, and also finding some meaning in this so that they can find some growth out of it. Because ultimately, this is an opportunity for them to look at what is going on, to shift to a growth mode and find something positive in this as a family. I mean, this is, how often do we ask for time to be home with our family and just do nothing, right? I mean, like, how often do you really have that quiet time or that connection to really do what you need? I just want to add this one post that came up yesterday because I just loved it so much, and I think it highlights really what's possible among this, and I asked her for permission to share it. So there's a mother who lost her son about 6 years ago. He was a Naval Academy midshipman. He died by suicide. And they've had a very difficult time, but they've come to TAPS and they've really joined with our model of stabilization, grief integration, and finding growth after loss. And yesterday she posted on Facebook, and I'm just going to read it to you because it was so cool. She said, "During this pandemic, I've learned a few things. Most important is that no matter what, I miss you more every day, my beloved Raleigh. I've learned too that no matter how much we have lost, in every sense during these last few weeks, we still have so much to be thankful for. And I've learned that ring around the rosy, rolling in the grass in my pajamas and looking my worst still brings joy to my heart. Thank you, Raleigh." And so I thought, geez, you know, here's this woman who has incredible pain, has had incredible loss, but has found a way to integrate his memory, but also find joy in those little things. And so that's possible if we give our, our clients, our survivors, our peers the opportunity to do so.
You know, with a lot of very powerful suffering, Kim, you just shared with us, people have been through really profound and powerful suffering.
Yeah.
Oftentimes people find meaning, and they find they find that they don't sweat the small stuff anymore. They look at things differently. Sometimes this challenge to our sense of life and death, this existential challenge, can also help us appreciate life more. Yes. So I want to thank you for sharing your thoughts and your experiences with us here today. And with that, I'm going to actually turn to Dr. Melinda Moore, who's done a lot of work on post-traumatic growth after the profound loss of suicide, and talking a little bit about, well, we could talk about that, but I know that would be something you would really eagerly want to talk about, but I'm going to wait to hold that back just a little bit to talk about providing that piece here when someone may be suicidal. I know that for a lot of providers, whether they're clinicians or peer providers or family members, but we're going to specifically talk a little bit, I think, more geared toward clinicians. I know a lot of people are afraid to treat suicidal people in a virtual environment. I know for myself, I have a 73-year-old woman who's been a longstanding patient of mine for the last several years. She had a long history of abuse and trauma, physical, emotional, sexual. She also has a severe mental illness that can range from moderate to bipolar illness that could range from moderate to severe. You know, she has had 14 suicide attempts in her lifetime. And my first inclination was to pick up the phone to make sure that she knew that we were going to continue our counseling sessions. And there were people, some of my colleagues, who were horrified that I did that. How could you put yourself at risk like that? So, you know, ethically for me, it was that do no harm. And the right thing to do was to make sure that she felt connected. She felt that her regular counseling sessions were going to be held, and that this was a time, especially isolation and pain are triggers for her. And so I wanted to just kind of address a little bit this issue of how do we get more information about delivering suicide-focused treatment using telepsychology and maybe helping people diminish a little bit of that fear?
So it's really good to be here with you today. Thank you so much for inviting me. You know, I think this is an opportunity for mental health professionals, behavioral health providers to really demonstrate leadership. There's a lot of information. We've been inundated over the past month, given the fact that so many providers are moving to telehealth. But this issue of treating suicidal individuals has been really pretty controversial. So I am part of core faculty in a clinical psychology doctoral program here at Eastern Kentucky University. And all of our students get trained in something called the Collaborative Assessment and Management of Suicidality within the context of a semester-long class called Understanding Suicide, from Assessment to Intervention and Management, where they really learn soup to nuts all about suicide, the epidemiology, the theory, the history, but then also they gain clinical skills. And if they so desire, they can then take those training wheels off and actually practice in our psychology clinic under close supervision by me, because I'm a CAMS trainer. I train clinicians all over the world in CAMS, but I also, like I said, train our students. And so we've had this clinic going for the past 5 years. We've been training students in CAMS, and we've been delivering this service on campus for the past 5 years. And when the pandemic hit and universities were making decisions about what to do, our university, in the middle of spring break, determined that they were going to shut down basically for the rest of the semester. And those of us on the clinical faculty and those clinical supervisors, you know, me in particular, I was very concerned about the 20 clients we had in our clinic who were being treated in the suicide-focused approach. I knew that many of them were students, the majority of them are students, but we also have community members. And I knew that they were being sent back home, very isolated, distressed, kind of this existential angst that, you know, we've been talking about, not knowing what's going to happen, you know, in terms of their semester, next semester, but then oftentimes going back to places that really are their homes, oftentimes difficult family situations, a lot of chaos, and then of course being quarantined with their families. And so this created kind of the perfect storm, as Dr. Jordan said earlier, for not only people who were vulnerable already and being treated, but then having further distress, perhaps further you know, concern about their health and their well-being. And so we as a faculty determined that we, you know, a lot of people were doing check-ins, a lot of universities, a lot of clinics were doing check-ins with their clients, and we were doing check-ins over spring break, but when the university shut down, we knew that we had to do something different, and we had to really take charge. And I've got to tell you, we didn't get a lot of direction from our university or any graduate psychology organization, but we decided that we had to do what was in the best interest of our clients. And so we had a small telepsychology clinic within the context of our psychology clinic, but it only had a couple of, it only had one account through DoxyMe, and it also only had a couple of clients it was serving. But we decided to really use what we had been created within our clinic and transition all of our suicide-focused treatment to telepsychology, to CAMS telepsychology. And within a week, all 12 clinicians were trained in telepsychology, and we began delivering services again, once again, to our suicidal clients in our clinic via telepsychology. This has been a real big learning curve for all of us. You know, those of us who've probably been trained in the last 100 years, you know, really feel more comfortable delivering these kinds of services face-to-face, particularly when you're trying to pick up kind of those nonverbal cues, facial expressions, you know, emotions. And with suicidal individuals, you know, being empathic, being compassionate, being collaborative is what we do when we're delivering this treatment. But we've really been able to modify, change, adapt, learn the technology. But also part of this has been having some faith, not only in the fact that we are delivering an empirically supported approach. CAMS is one of the 3 empirically supported approaches for treating suicide, along with dialectical behavior therapy and cognitive behavioral therapy for suicide prevention. So we had this empirically supported approach, And then we also have a platform, telepsychology, through HIPAA compliant format that allows us to then deliver this treatment. And so I think it's not just a shift in kind of skills, learning new skills, learning how to sort of translate this to this new format, but also having some faith that we're delivering empirically supported treatment in a format that actually is also, there's some research now around telepsychology that demonstrates that it's also an effective form of treating individuals. And so I think it's been more than just this kind of shift, having to do something that's in the best interest, but also really kind of a profound, kind of opening up of all of us in terms of how we do what we do. And, that really kind of brings up this issue of opportunities and how behavioral health providers can demonstrate leadership and how to really manage these kinds of crises. This has been not just a crisis for our clients, but it's been also a crisis for our doctoral students, for the clinical faculty. We've all had to manage our own distress, being very concerned about the clients that we're serving, but also our own, in our own personal lives. But I think what this has really done, I know for me as a clinician, as somebody who's, a super clinical supervisor responsible for the lives of these individuals that we're serving, is it's really opened me up to kind of a new way of doing and providing this service. So, we talk about meaning making, we talk about growth in the aftermath of these events. I think I'm already seeing growth, certainly on a professional level. And I think also, on a personal level too, it's incredibly satisfying to know that these individuals that we were previously serving face-to-face and now serving via telepsychology, we are really profoundly serving their needs. These are individuals who are alone, in distress. But the great thing is that, there's the response to this crisis, and oftentimes how we are now treating them has changed as well, because all of it has been shifted. A lot of the students have gone back home, and like I said earlier, they've gone back home sometimes to family environments that were very chaotic. As Kim said earlier, families have really had to learn how to negotiate some of this chaos and some of these conflicts. And so actually, we are finding that while some of the people that we're serving, are very distressed by the isolation, so we're having to necessarily, and their drivers for suicidality are also changing. So we're having to necessarily shift the interventions. But we're also finding that in some cases, this quarantine hasn't been actually a bad thing for some families and some individuals. It's given them a chance to kind of have more intimate time, also to kind of relearn how to get along and address these family issues, but also for a lot of individuals exploring, what next? What do I want in my future? So the exploration becomes not one necessarily of crisis or angst, but of, what do I want for my future? It's given them really an opportunity to explore things that they may not have had the opportunity or time to explore previously. So I would have to say it's a mixed bag in terms of what we're seeing. We're definitely grateful that, we had this telepsychology clinic in place and that we were able to transition over so quickly. My colleague, Dr. Michael McClellan, is an expert in this field. I've certainly learned an awful lot from him about this, and he's taught us all how to use telepsychology and deliver CAMs via this platform. But I think also, it's been such a lesson in sort of the fact that, suicidal people are not homogenous, and people responding to this crisis, and given the fact that they've been in this kind of vulnerable, fragile place previously, they're not responding in a homogenous way, but everyone's very different. And we're finding a lot of heterogeneity in this, in the response to this crisis. So I think that offers a lot of promise. And also I would just have to say that I think how we as clinicians are responding to the clients we serve, and really helping them understand that while, yes, these are not ideal conditions, it can create distress, it can create certainly these grief reactions, but there's also an opportunity for these changes that are created within us to help us grow. And I know from the work that TAPS does, they actually do things. For instance, their peer mentors. By being a peer mentor, you are promoting growth. It's not just a matter of buffering against distress, but it's really a matter of promoting growth within yourself. So there are things that we can do. We can encourage the people we're working with, or even our own family members, to do to really promote growth given the circumstance.
I know that, working with you and Kim and certainly Jack, we all listen in from a strengths perspective. From the moment we hear a suicide loss survivor come in with us, we're always looking for those, as Kim and I often talk about, those opportunities for growth, or really honing in on someone's growth and strengths. While we're working with people, it's not just about risk, it's also, and it's not about pathology, it's about looking at people's ability to grow and to change, and listening in for strengths. I want to ask you a question, just a little bit turning back to this idea of leadership. So, addressing sort of the micro, the macro, and the meso level. I made a micro. I'm an individual practitioner. I made a clinical decision. I had no one that I needed to go to make that decision. You made a decision. Your team made a decision. And what would you say, though, to agencies and other individuals about making that decision to treat potentially suicidal clients, or clients that are suicidal? What would the message that you would send to those who are still really fearing this?
Yeah, I don't think it's unusual for clinicians to fear treating suicidal people. Most clinicians haven't had any training. And the standard of care in this country is really hospitalization and then using psychotropics to really address suicide risk. And we now know, because of the new science around suicide, and of course, Kim and Jack and you, Jill, you all have been part of this community to develop the new science around suicide. But what we know clinically is that actually hospitalization, multiple hospitalizations actually confer more risk, and that there's limited or mixed evidence to show that psychotropics really address suicide risk among these individuals. So we have to do things different necessarily. And like I said, we now have these empirically supported approaches. So I think people, clinicians, organizations, agencies really need to look at the new science around this, have some faith in the science, try something new, because we now know that standard of care isn't good enough. And we now know that there are actually approaches that really keep people out of the hospital, really look at what is driving the suicidality, address the problem, while at the same time also helping people learn to cope differently, because we know that suicide is sort of a long-term way of coping, but also developing a life worth living. It's not enough just to no longer be suicidal, but it's developing a life that you're attached to. Kind of like what Jack was saying earlier about being attached to something, a life that you want to live for. And so that's what we do in the approach in CAMS. And I would just really encourage agencies to really reflect upon their fear. What are they fearful of? Are they fearful of a board complaint? Are they fearful of being sued? Because, you should be fearful of a board complaint or being sued if you're really not engaging in a practice that has this kind of science around it. And when you are trained in it, and when you are using a vehicle, whether it's face-to-face or whether it's telepsychology, that's demonstrating effectiveness in working with people, then I think, that fear kind of goes away. But I think it's anything new. Change is hard for people. Change was hard for me. And I've learned over the past couple of weeks just how resistant I am to change. But being on the other side of it now, I'm also inspired, and I feel really kind of free. I don't just have to see my suicidal patients in my own private practice or my suicide bereaved patients face-to-face anymore. I can now see them when they may really need to see me, or we can sort of address those geographic, issues. If I'm in one place and can't be in my office, then we can still meet. And so I think that it's very much a mindset shift. And I would really encourage people to really reflect upon what they're scared of.
Jill?
Yes.
Can I jump in for a second? Melinda's told us so much about CAMS. Melinda, you want to say something about how people can find out more about CAMS and where they can do that? Because a lot of the CAMS training is available online, is it not?
Yes, at camscare.com. It's CAMS, C-A-M-S, care, C-A-R-E.com. You can purchase online training, and then there's all sorts of things. There's a book, Managing Suicidal Risk, and it's its second edition. It's excellent, by Dr. David Jobs. And then I'm a trainer, so I go out and do in-person role play trainings. But the 3-hour online training is really excellent. Of course, behavioral tech, provides online training for dialectical behavior therapy. And then of course, my colleague Erin Goldman, who's the new clinical division director of AAS, she actually provides CBT for suicide prevention through webinars. And so a lot of these empirically supported approaches also are available online. So I think we have to really kind of, open our minds to the online environment, whether it's learning ourselves, being trained, and then also providing this service.
I'd like to kind of open up the conversation because I think it needs to be addressed about what we can do if someone is suicidal, like what are the sort of the best practices. Again, these are just not the hard and fast rules. These will be best practice tips. I know that for me, I make sure that I always have a phone number of my client, where they are. I know their physical location. I have the phone number of their local 911. I also have the phone number of the support person in their life. Sometimes I do work with people who live alone, so that could be difficult. I just wanted to kind of jump in and ask everybody, what can you do if you're concerned?
Well, one thing is also to let people know about, both clinicians and the general public, about the National Suicide Prevention Hotline. I don't know how long ago, maybe a decade ago, in the United States was established a single number that you can call from any place in the United States. And I'll give it to you in a second. And what it does is it patches you into a local crisis intervention and suicide prevention center. By local, I mean wherever you're calling from, you'll get connected to a crisis center in that area. Anytime you have a concern about a client who's suicidal, anytime you have a concern about a family member or a friend who's suicidal, if you're concerned about yourself being suicidal, you can call this number 24/7. It's 1-800-273-8255. And another way to remember it is that it's 1-800-273-TALK, T-A-L-K, which translates on the telephone dial to 8255. So that's just a resource that everybody ought to know about and have ready, and also to pass it on to other people.
I think also the crisis text line, or the crisis text, 741-741. A lot of people, people of all ages are now feeling more comfortable texting. So 741-741 is also another outlet for individuals to be connected to a trained crisis counselor.
And I would say, Jill, that, there's people will have like preferences about who they will talk to when they're in crisis. So it's really important to give the crisis lines, but also give other ways of connecting that may be a bridge to the crisis line. So giving them like a peer-to-peer line, like TAPS, which is 1-800-959-8277. And if you're grieving the death of a loved one who served, or you're active duty and lost a dependent, at any time to any kind of death, you can call us 24/7. And we will usually assess for risk too, if we get an idea that this person has suicidal thoughts, and we can connect them by warm handoff to the crisis line. So there's also the National Disaster Hotline that I talked about when I was first opening up, which that number can call for any kind of related issues to COVID. And they have psychological support, but also physical supports like, money and other things that you may need support around now. And that number is 800-985-5990. And it's also a 24/7 line.
I would also encourage, for me, I'd also encourage being a assistant professor, an adjunct professor with a student who recently had a suicidal client. I would really highly suggest most supervisors at clinics and agencies to really make sure that you have protocols in place for your students, and as well as your employees of your agency as well too, to really talk about this. I'm sure a lot of people have, but I think that's a really important part, especially for students, as you know, Melinda, making sure that you have a protocol and you're having these conversations with them. So before we leave today, I wanted to talk a little bit, just kind of end on talking a little bit about post-traumatic growth and what you think some of the growth out of this may be for people. And what is post-traumatic growth? Some people don't even know that concept. I'm making an assumption. Here's my assumptive world. I'm making that assumption that people know what post-traumatic growth is. Just really briefly, Melinda, what can you tell us about it? And I thought maybe you can all chime in on.
Post-traumatic growth is defined as positive psychological changes in the aftermath of a shattering experience. It's got to be shattering of that assumptive worldview that you're talking about. And the idea is that it's when you engage, after you begin to manage your distress, you begin to engage with the event. It's a cognitive model. And the idea is we think about what's happened to us. So you engage with it, you go back, you revisit the event. And it's through that revisiting where you actually rebuild how you understand your world, and you might develop new goals, new aspirations. And it's through that actually you grow. So it's not the event itself that actually creates the growth, it's the changes that are created within the individual. And when I talk about changes, I'm not talking about they're looking at things differently. I'm talking about they're actually changed as a result of these changes.
Kim, is there anything?
Yeah, I think I would just add that, just as we saw with Maria's post, is that there's a change in the way they kind of experience the world around them, that maybe out of this crisis you have a new appreciation for the little things that bring joy to your heart and to your world. Doing a puzzle with your grandchildren, noticing a sunset, noticing the grass and the smell of the grass. Like, there's just a different way of experience the world. Your connection with your spirituality may have changed. You may get to the other side of this and feel like, wow, I'm actually a strong person. I actually can handle things in a way that I didn't know I could handle it. So there's all different pieces of post-traumatic growth that are a part of this, that if you help people see that and grab onto that, they can become stronger and more connected to the world around them.
Well, I'd like to thank everybody for joining us here today. And again, if you or someone you know is in suicidal crisis, the national helpline number is 1-800-273-8255. And Kim, Melinda, Jack, I'd like to thank you for joining us here today on this very special topic. And for all of you that are listening, be safe. I hope you're practicing CDC and Dr. Fauci's recommendations for physical distancing. And be well. Hopefully you'll tune in to more of ADEC in Conversation. And I want to thank all of you here today again for this very important and vital topic.
Thank you.
Thank you, everyone.
Thanks.